حياكم الله جميعا. Welcome everybody. We are pleased to have Dr. Ahmed Al-Amrani. He is a well-known figure in the adult congenital heart diseases, also in the pediatric interventional part and pulmonary hypertension societies. Dr. Ahmed is and senior interventional cardiologist, if I call him, as because I am interventionist, and that's what I lean to. And I was pleased to work with him and really lucky to have him today. He accepting our invitations. Dr. Ahmed has a huge experience in the pulmonary valve, plus the other congenital heart diseases, and really he is a proctor for more than one valves with the new valves in the market. So we ask him today to give us a good talk as usual. And I usually enjoy his talk, also his discussion of talking with him. I enjoy it. And luckily he accepting that. So with short notice, it's only 2 weeks notice, and he really support us to give us this usual beautiful talk. So welcome, Dr. Ahmed, and all of you welcome to share with us. At the end of the meeting, the question and answer. By the end of the meeting, we'll allow all of you to unmute and you can ask your questions. تفضل دكتور أحمد. حياك الله وشكرا على قبول الدعوة. طبعا شكرا للدكتورة الجوهرة السعيد، لأنها صراحة هي المنسق والخلف الذي يشتغل خلف الكواليس. شكرا للدكتورة جوهرة. جوهرة is a senior fellow in our center, King Fahd Medical City. حياك الله دكتور أحمد.
شكرا، حياكم الله جميعا. السلام عليكم، بسم الله الرحمن الرحيم، والصلاة والسلام على رسول الله. First of all, thank you for giving me this opportunity. It's always nice to share some of these informations and discussions, more of a discussion rather than just spinning information. So please feel free to document your questions and we can discuss them at the end. So what I thought in the discussion of the topic and the title, I thought just to give a heads up, I think most of us know there are pulmonary valve placement in the cath lab, and I thought just to give you a little bit of a hint where we are heading and what kind of valves that are available in the country and what we should be watching for preparation and follow-up of these valves, since they are a new technology in the field. Nothing to disclose. So there is a sequence of intervention to the RVOT, whether it's a pulmonary regurgitation that cause RV dilatation and dysfunction, residual lesion from a VSD or branch PH stenosis that will progress or even harmful to the RV, cause exercise intolerance, heart failure, and may lead to arrhythmia and sudden death. Usually pulmonary regurgitation is well tolerated, as we know, from 10 to 20 years. They usually become asymptomatic. There is a progressive right ventricular enlargement, right atrial enlargement, atrial and ventricular arrhythmias, right heart failure, and progressive TR, which is an important part of the assessment and indication that has been introduced recently into the guidelines. Then it will lead, of course, to a progressive right-sided failure that will end up to multi-organ failure. This is a famous chart that I usually always use with the RV dysfunction, which is basically a very marked point around 25 years after the operation of RVOT intervention, where arrhythmias and problems with the survival happens to drop dramatically compared to the progression over the years. Not really known why this 25, but most probably a hormonal, developmental maturation of the ventricle and the long-standing of the sequelae of intervention to the RVOT appears after those years. From the arrhythmia point of view, and this is usually what I tell the fellows is a board questions, the most common and usually around 30 or 40 years of age after the repair is usually the atrial arrhythmia that gets early problematic with these patients. Subsequently, the ventricular tachycardia comes a little bit at a later age. So keep that in mind, is usually the atrial arrhythmia rather than ventricular arrhythmia that early presents and the prevalence in these kind of patients. Abnormality in the hemodynamics from the progressive RV dilatation and TR. This is one of the leading problems with the hemodynamic abnormality that we monitor them by echo. RVH in case if there is an outflow obstruction for residual obstructions, the scar from the RVOT and the aneurysm due to unhealthy tissue or from the previous ventriculotomy, residual shunt that add more volume and pressure to the right side of the heart. Plus, which is an early recognition now, we are very known that this RV-LV dysfunction and the septal shift that harmful the LV becomes a more important assessment in our indication for intervention. Electrophysiological is always problematic in this patient, and it becoming very hot and very important in the assessment for pre-intervention in these patients with the current devices, especially the ventricular tachycardia. Factors that lead to the degree or the worsening of the PR, whether it is the regurgitant orifice, the RV compliance, the diastolic pressure difference between MPA and RV, the capacitance of the PA branches, that some of these patients differs. So this is why some of them will have a PR significant and affect more compared to the others. And of course, the duration of diastole, the longer, the more effect on the RV. This is Tal-Giva 2011 famous chart. It still stands as a sequel of the tetralogy of Fallot with the sequences from the right ventricular dilatation, the ventricular synchrony, and the LV dysfunction. But one most important thing, not just the LV, remember also the age at repair, and there are also some genetic factors that we are trying to recognize in these patients. Why do they develop a more worse PR compared to the others, though they are the same lesion? Timing of valve replacement, it has been already published. There are clear guidelines that assess in our timing of intervention. It become more easier with the 2018 guidelines, the ACC and the European 2020, that has also showed that the mild PR of the RV enlargement, when to interfere with these patients. I'm not going to go into details, it's available. Subsequently, more importantly, was basically the factors that we are using now. Remember, it's not only just the RV volume of the diastolic. There is a more important component, which is the systolic volume index of the RV, the 80 cc. It's a very important factor now. The ratio between the RV and LV is an important presence of obstruction of the RVOT that can actually mask your ventricular dilatation because of the hypertrophy, and of course, exercise intolerance and the presence of LV dysfunction. And keep in mind, not just these numbers as a figure, but progression toward these numbers and how fast it progress. You have to keep it in mind when you assess these patients, because you notice that if there is a jump by 10-20% in a year or 2 or 3, you know that it's going to reach it sooner rather than later. So basically, when the patient is asymptomatic to intervention, it's going to be prevented. One of the new tools that IGBI actually has published, and I would recommend that everybody look at IGBI publication in this regard. He has very nice couple of literatures about how to assess this ventricular function, both the left and right. But this is the strain of the right atrium has become an important tools to assess the incidence of arrhythmia. Sort of like a standalone assessment, not related to the QRS duration or presence of VTAC. So there is a relationship between the right atrial reservoir strain measurements and the incidence of atrial arrhythmia in these patients. So this is an important tool that some of the advanced echocardiographer and echocardiographer labs can utilize in these patients and help in their early recognition. We understand whether it is when you compare pulmonary valve replacement and no pulmonary vascular replacement, there is a definitely change in their outcome and their survival when you intervene from the time of surgery. So this is a very, very well known. One of the things that this is from the European new guidelines is the patient with RVOT flow tract. You have to, there is an indication of class 1 indication with transcatheter pulmonary valve has been introduced in the guidelines, which is a very important to our patient when we discuss them between surgery and no surgery. Importantly is looking at down here at the bottom, which is class 2A, looking at the introduction of the in-systolic index, which is 80, is an important marker in comparison also, and the same in line is the in-diastolic volume of 160, 150, in addition to the TR. TR is becoming an important anomaly or progression that you have to keep it in mind in your assessment. Sometimes you may not reach these, but you will have a progressive TR, you will have a progressive dysfunction of the RV before reaching the volumes. You have to keep it in mind. This is a nice also paper by Igby looking at the same right atrial reservoir strain. It actually becomes very significantly important when you look at the surgical and trans catheter remodeling. It actually can show you a difference. So this is a remodeling after, the red one is after the percutaneous valves, and the blue one is after surgically. Definitely the catheter intervention has a better remodeling, and of course, because the surgery will require a redo, they're going to be reintroducing a new scar to the right atrium. In addition to the right atrial pressure, not only that, but also the RV global longitudinal strain assessment by echo is different. One of the things that is still not yet, because of the survival years, we are just looking at this paper is only looking about 5 to 6 years. The dysfunction of the surgical and the percutaneous valve is still surgery is a little bit superior compared to the percutaneous. But to remind you, this is an old valve systems. Not the new balloon self-expandable. And the other thing is, remember, this is only just a short-term follow-up up to 5 years. We do have the surgical and the percutaneous pulmonary valve interventions. Looking at the type, we have a surgical. This is the standard. Previously, that we know that it's the standard. It has a favorable remodeling. It is proven effective to improve the RV volumes. The problem is the durability is limited, and unfortunately, bioprosthesis will fail eventually in the surgical. So keep that in mind. Introducing the valves and surgery multiple times to these patients is going to be detrimental to their lifestyle. The introduction of percutaneous valves since the 2000 have changed this. We are moving now toward the RVOT, not only just the conduit valves. Now we are in the territory of native tissue valves, and we've been expanding this more and more from the surgical point and valve of implantation, and we are reserving the surgical intervention for the least favorable percutaneous pulmonary valve procedures. There are papers that has been comparing percutaneous surgical to percutaneous valve implantation. This is a large cohort of patients. Nothing really major from mortality point of view differences, not difference, but definitely from the surgical point of view, they do have a lot of more morbidity, which include the pacemaker implantation. There is an increased risk of cardiac arrest, long time of hospitalization, more cost, bleeding, blood transfusion compared to the percutaneous valve. And this is a sort of like a no-brainer that anybody can understand and recognize it. One most important thing in this era now with this self-expandable systems, the electrical assessment in these patients. I do believe this is need a vigorous assessment in our patient. There are many papers that has been published looking at the risk factors of sudden death and arrhythmias, whether it is the age of the patient, older age at repair, older age at pulmonary valve replacement, the surgical techniques, presence of SVTs, symptomatic status, the LV dysfunction, elevated LVEDP, the QRS duration, and the shape of the QRS. There are many articles have been published about this and the electrical abnormality in these patients. There are 4 anatomical isthmuses that we need to keep in mind. Our EPS colleague or electrophysiological team, they will always remind us there are an area between the tricuspid valve and the isthmus where it is the RVOT patch. There is around the transannular and around the VSD patch, that always cause a problem with these circuits and abnormality. Usually, as we know, this is the substrate that basically is the focus or the initial point, their abnormality. Subsequently, with progressive fibrosis, with age, volume overload, dilatation and hypertrophy, and the aging, in addition to the QRS prolongation, will basically cause more and more of a slow conduction process around these areas. Subsequently, with any trigger, PVCs or SVT, that will basically throw them in a VTAC or SVT problems, and depending on their hemodynamically and their assessment. So this is basically looking at it at the electrical part. Do we need the APS prior to any percutaneous pulmonary valve? This is the study by Boyer from, this is the earlier percutaneous system, which is the balloon expandable ones, looking at from 2000 and 2018. They looked at 77 patients with high-risk prevention ASD score model, and they actually had up to 24% of their population where they have induced ventricular arrhythmia. So it is really of a matter of importance to these patients. This is, remember, with the older generation that do not cover or isolate the RVOT with the current valves. So keep that in mind. No deaths or ventricular arrhythmias in non-inducible group, which is a very important in this part of it. Though it's a small number of patients, but it's also important to us. Remember, with the EPS, the debate whether you do it or not does not comes without a risk. There is a catheter ablation associated mechanical trauma, and this is a problem with endocarditis. And we know the issue with endocarditis and the percutaneous valve with a little bit of a higher incidence compared to the surgery. So you need to keep that in mind and become more of a vigorous. So looking at it from an assessment of EPS, I think we need a center who is implanting these need to have a vigorous non-assessment protocol, which include ECG Holter, and a stress test prior to any intervention to this RVOT, whether it's a surgical or not. We need to understand there is a limitation of these studies. So any of issues, or we should have a low threshold to have an EPS assessment to these patients. And of course, we need the long-term studies to determine whether we should standardize our protocol to include an EPS in these patients or have more of a selective tools to send them. Part of the planning of this procedure with these kind of new devices, CT is becoming a very important tools in these. It is a low contrast system. You need to have a good collaboration with your radiologist or cardiologist. It's basically very good in basically retrospective. You can regain, reassess, recut systole, diastole. As most of the base as measurements now for the device and the sizes is depending on CT that you get and acquire. You get a planning and a patient selection from this imaging by the company that you're going to send. They will give you send you sort of like a fit analysis for this. You look at a red, which is basically the systole, the blue is diastole, and they implant the valve for you. They give you the landing zone, the bifurcation of the PA, and how safe is that valve with alignment. They don't only give you that, they give you also different cuts of the outflow beautifully. They give you how the valve going to be landing virtually on the CT itself. Not only that, but also they give you different landing spots. If you're going to put it supraannular, annular, or below the annulus, how the valve is going to be shaped, depending on your shape or systole and diastole. It can also give you the cross PAs and how it is analyzed and how the force is there. It gives you a landing zone and how safety it is from the PAs. And you're looking at, when you go look at this from for example, and it doesn't only give you this, but also give you each spot here and basically give you a direction how that lumen going to look like from inside. So this is basically at the distal bifurcation. You see how the PAs is sort of like opening as a kidney shape, opening for the branch PAs. Below a little bit, you will see how that diameter look like more of a rounded, and it will give you also the cross-sectional measurements. You can see here 36 millimeter, 48 millimeter. This is at the distal part of the MPA before the bifurcation. Mid part is 33, and also the proximal part. So each point of this is give you a cut. Not only that, but also look at this patient, for example, how systole and diastole in a patient look at straightforward. Other patient RVOT is a little bit more of a horizontal compared to other patients. Not only that, some of them even not a horizontal, they tip even downward, and some of them will have also an acute angle. So this is the beautiful about CT scan. It gives you the cuts and the shape to imagine and give you an imagination how the PAs and how the valve, basically virtual implantation, how the valve is going to be implanted, considering the cross PAs. And also here, if you look at the right corner of the screen, is also the multiple dots and how the valve is going to be look like, and also give you like the red dot is the distal flare position, the proximal part here, and the blue is where your valve should be landing. So it gives you sort of like an idea how you're going to land the valve when you position it and release it. One important thing which I utilize a lot in these patients is actually when they give you the virtual cut angiogram, and actually they give you a hint or earlier hint, what is the angle if your angiogram will be perfect. So for example, you look at this patient, this is the PA straight AP, and there is the fold of the LPA is not very clear, but when you are angling more of an LAO cranial, you will see the bifurcation of the PAs, but when you angle more of an RAO and a little bit of a cranial, you see the lining of the RVOT with the RPA when you position your wire. So the wire is going to be better positioned in the LPA for your stiff device system, and you can see how far is your LPA. And when you position this paper in front of you and the screen, you can basically get a better alignment of the device compared when you see it in the right lower corner when you have it. And if you have a software in your cath lab where a fusion image is accepting this, it will be even more fruitful for the operator to lessen the time and decrease the fluoro exam. And this is another example for this patient. Some example of this patient, you can see the best angulation is actually a caudal in this patient. So a caudal will give you the bifurcation. You would never imagine that will be a best. You will maybe waste a couple of injections in the cath lab before, but the CT with the cuts, they actually can give you a heads up how do you perform this. And this is the same patient, give you both alternative view, how you're going to be opening the PAs very well when you position your camera. So I utilize this a lot with these patients and give you really a heads up. The valves that are available in current era now around the world, there are many valves. I list them here. The most important thing that in our country now, you have almost all of the valves that has actually no other place in the whole world that have access to these, which is approved by FDA. If you look at Harmony, it's just started implantation, got just the CE mark this about 3 months ago, and compared to Saudi, who's been doing it for more than a year. So in our situation, we are being blessed, alhamdulillah. We have all of these access to all of the valves at the type that needed for different type of RVOT, and I will go over them. So these are the most self-expandable valves that you're going to be watching and seeing and most probably using. If you look at the venous P valve, which is the larger ones, you look at it from a perspective that it has the frame. It has different sizes. The most important thing is the diameter. It has multiple sizes ranging from 28 to 36. So the diameter here, you will have a 28 valve up to 36 millimeter valve. And when you go higher, of course, the diameter above here will be different, and also the length of different. This valve is an anitole stent, both leaflets and covering the distal part is uncovered. The proximal part is covered to avoid paravalvular leak. There are radio-bake mark, whereas the valve is being hosed. And remember, there are two hooks that is available. This system still requires a crimping system in ice, though the most important thing is part of it is also remember that the length of the valve is important, but the newer update of the venous valve, it's going to be including a shorter. Remember that this part, which is the D, is now available in two sizes, 25 millimeter and 30 millimeter. So keep that in mind. You're going to add 10 and 10 to the distal and proximal part. So it is a long system valve. They're going to come up now with a shorter system, which is 20. The delivery system is going to be different. It has the 3 types of delivery system depending on the size that you use. And you can see the model accordingly you will use it. And the other technologies coming also is the dry tissue valve, which is basically out of the box. you position it without needing to have an ice. The other one, a famous one, is the Harmony. Just remember also the venous P valve. The frame is cut and prepared in US, but the porcine cover is being done handmade in China. Harmony is all done in US. It's a laser cut. This is why it's the wires is a very soft system compared to the other ones. And again, remember this inflow and outflow is all covered. So this is basically a little bit an important thing, especially when you deal with the distal PAs compared to the other two systems. The venous P valve, the distal part of the crown is where the bifurcation of the PAs is open, and this system or the Harmony is closed. It has very nice delivery system, straightforward. You load it, and basically when you position it, you unsheath it. The other newer one, this has just recently been introduced in Saudi. Only 1 or 2 centers now being using. It's the Altera system. It's basically the same as the Sapien that we use, but they actually instead of the pre-stenting that we used to do for the Edward, they have now the Altera, which is basically a frame, a pre-stented frame that basically you open it up in the RVOT. The distal crown is, you can see it's an open cell. The proximal is closed to prevent a paravalvular leak. And this is basically the measurements of it. And the length is about 49 millimeters. So you need to require a 49, when it is fully expanded, a 49 millimeter RVOT. So to keep that in mind, compared to the Harmony, the length here is 55, and here is almost the same, 43 millimeters. So keep that in mind when you assess the patient. Remember, with the Altera system, it already comes with covered already, so it's protected. You release the pre-stenting, and then you come up with the valve, which comes in one kit. So that's one of the disadvantages in our system in Saudi. This system comes in one package. So when you buy it and open it, you have to use both in the same system. One thing also, the Sapien valve used in this is the Sapien 3, is not the Resinia system that is now being introduced in the aortic valve. So keep that in mind. But the sizes is available. It is prepared and set for 29 millimeter Edward valve. So one of the things that we keep them, the ACT during the procedure, the antiplatelet therapy for at least 3 to 6 months, dual. Some of us will use single for 6 weeks. It depends, but aspirin usually will be used for life. And there is also a discharge and antibiotic prophylaxis for life, SB prophylaxis and discharge transthoracic. Some of the other issues that you need to keep in mind, whether you're comfortable with, is whether you do the per close, figure of 8 system to secure or seal that IV big hose access that the venous access. Just to have a follow-up with these valves, which is very important in this talk, is the valve thrombosis. You need to keep eye on them. Valve frame distortion, instant restenosis, valve endocarditis, and frame erosion. These and arrhythmia. These are 6 new things that we need to understand and keep in our mind when we follow up these patients. For example, the valve thrombosis, it can happen up in one of the studies by Goldstein and Glipsy-Matt. They looked at these patients. Up to 3% of these patients can develop them. The good thing is usually earlier in their post implantation process. Subsequently, they usually are free. Once they pass 1 year without it, usually is less of a less. There are, whether you do medical therapy, whether you do ballooning or valve on valve, that has been treated in these studies. Other thing is known that is a frame fracture. We've seen it with the ASD, some of the ASD type of ASD. We've seen it some of the branch PA stenting, and the self-expandable is not of a difference from these. Steenberg has looked at these in the Harmony, and actually there are 6 patients reported with distortion and affecting of the valve functionality treated with valve and valve, whether it's a Melody or a Sapien. The Sapien 29 was used in 4 patients in the 25 Harmony, 25 millimeter Harmony, and the 22 Melody valve was used in the 22 Harmony system. So these are some of the examples that can show you some of the distortions of the frame in these patients from this is from the if you look at it, this is from the Altera system. You see the proximal part of the RVOT is not opened, and you see it here very nicely seen here by the CT. Is like you see how that frame is basically fractured, is not like opening well. And this is the Harmony outside, and the more brighter one inside is the Sapien valve has been put. So just keep that in mind. Looking at it from the Harmony, this is the Harmony case. Looking at it from implant time, there is not much of a gradient. Subsequently, there is a progressive in the gradient, and there is a change in the frame shape and fracture. Ballooning sometimes can be helpful. Sometimes you need to go in and do a stiffer system, like a stenting inside, and then subsequently you go ahead and put a Sapien valve to manage all of this problem, the fracturing, the distorted the frame with a stent, and subsequently you put valve and valve like Sapien. Whether you do a stenting before or you just go in with a Sapien, I think it's case by case. And this is sort of like on table vitro, how this valve going to be look like, putting in an Edward inside the Harmony which being reported. Looking sometimes with the frame fracture, you keep it in mind. Sometimes you will have a frame fracture, but no dysfunctionality in the valve, especially in the smaller one, the 22 system of Harmony. But I don't think if there is no change in the valve functionality, no arrhythmia, nothing, I wouldn't do anything about it and just keep monitoring the observation. Endocarditis, as we recognize, this is a big challenging with these patients. Where there is a paper by Goldstein looking at it, and definitely it is a different entity that we need to pay attention to it. Having a patient dental workup done prior to the procedure, less than 6 months, is actually more of a higher risk to these patients, and or doing a dental procedure within 6 months procedure. So at least dental issues need to be tackled at least 6 months prior to the cath, and deferred after the cath by at least 6 months. This is looking at another patient where is the thrombus formation, and looking at it when they try to do a penumbra and trying to get it out, clearing the valve, and to become, there are still some thrombosis there, but it's cleared, and the function of the valve is still maintained. So no further intervention. Valve erosions, it is of a concern. It's because we are dealing now with a larger system in a native RVOT, so a thin tissue that has been sometimes not being operated or no fibrosis around it. So still remains a low. Whether the risk factor is anatomy, tetralogy versus PS, history of previous operation, location, and the valve type, I don't think this has any of these has became prominent in causing or becoming an independent causation factor for a valve erosion. I do think longer follow-up is needed, but you have to remember that it is also an important factor, especially when you follow them up in the future. The PVCs and SVTs can happen after. This is why on telemetry, if the patient has PVC frequent after the cast due to the irritation of the RVOT, maybe a 6 weeks beta blocker is helpful to cool that down until the device settles. From these studies, only 7 patients required antiarrhythmia, and 90 patients of the patient, and 7 patients required antiarrhythmia, and maybe 2 or 3 from the study required longer term of antiarrhythmia. They only require these arrhythmias for the first 6 to 3 months. Follow-up, I think regular echo is the gold standard for this follow-up as an outpatient. Consider X-ray or chest X-ray just to look at the frame shape. This is why I think important to have a good fluoro store after the valve replacement, and looking at the X-ray after the procedure before discharge from at the time of implantation. Fluoro may be needed if there is increase of velocity, and to consider that also at the time of the cath. So maybe bringing him to the patient and initially assess him by fluoro. CT is actually becoming more and more important, especially when you have a distorted frame versus thrombus. So this is an important tool that if you have a gradient change, there is a frame maybe look like different, no fracture, you're thinking about thrombus or a frame distortion or stenosis, CT will be very valuable tool to help you. There is no clear really anticoagulation in this matter, but some of us will do dual platelet it for 6 weeks. And I usually only just now, for now, I do aspirin, but some of my colleagues will do aspirin and Plavix for 6 weeks or 3 months, and then subsequently continue aspirin. Keep that there, the frame stenosis. Valve-in-valve is very effective in treating some of this distortion. One of the most important thing about the last summaries, 2 or 3 slides, I want to spend a little bit time. Real estate in these patients, meaning the area of the RVOT, is very important in our patient, and I should stress on it. The larger, the better. So the larger from implanting a valve, if you can do it, is better. Take the advantage. You have a larger RVOT. Remember, the surgeon, when they take them and put bioprosthesis for these patients, they resize that RVOT to a smaller size. Take the advantage of larger RVOT. That will delay them further down in the road. So instead of maybe 1 or 2 surgeries in their half-life, 3 or 4 surgery will be only 1 or 2 surgeries. Remember, we have not seen yet the redo surgeries for these valves yet. It's going to be another challenging from the surgical point and surgical colleagues. We will wait and see how that will be panning out in the future. But percutaneous pulmonary valve can provide sizes larger than the surgical valve, and this is what we know. And actually, the durability is going to be an important factor to look into that. Follow-up, we need to understand the antiplatelet. We understand the arrhythmia, the early dysfunction, and the infection. So these are the most important 4 things that you need to follow and make sure that you understand and explain to their family. The self-expandable percutaneous valve have provided a less intervention to patients with RVOT dysfunction, new tools, more vigorous assessment pre and post. We have to learn it. We have to be comfortable with it. We have to understand. Now we are doing images that getting assessed by companies outside of our institutes, bringing these images back to us. Some of these images and the terminology they use may be a little bit different from us. Some of them may red flag it, maybe orange flag it. They may say not it's possible in doing it. It's not prohibitive. So remember, these are imagers. They are not an interventional team. So imagers are not the people who are putting the valve. So you have to discuss it with your group, with your expertise around you. There are other experts, interventional around, that can help you and assess you. We've done, some of us maybe known that we've done cases that some of these images that you get a report that you cannot do it and you will be able to do it. And it's always going to come in your life until you get comfortable and your institute build their own system of assessment of imaging. Registries, I think I do believe needed. I've been hammering all the companies in Saudi Arabia to have some form of a registration process to any valve being placed. It's not about center, it's actually about valve functionality and to give the best to our patients. There are valves are good for certain patients and there are valves are better for other patients. So just to be able to, you have them all on your shelf is good, but also knowing which is better for a patient is more important. From my personal experience, I built this schematic table to help me in understanding and also explaining and figuring out how to go around with the valves. So now in Saudi, we have all of these this is an Altera system. You can say it is a mixed, whether it is balloon expandable or self-expandable, but as I put it in the self-expandable because of the Altera pre-stenting. So it opens up by itself. So to keep in mind, so for a large RVOT, the big standing in the group is the venous P valve. It has a maximum diameter up to 36 millimeter. Altera has a good chance, but remember, it gives you a stenting, resize the RVOT to the maximum of 29, the sapien valve they're going to put in. Harmony, yes, it's large, RVOT, but the house of the valve itself, the maximum diameter is only 25 millimeter. So it's good for patients, good for adults, but remember in the future when you trying to go into valve-in-valve process, here where I put it in this column, when you do the valve-in-valve, you look at the larger area that you utilize, it will going to give you a more chance of valve-in-valve for many, many, many times in the future. And has been reported in the venous B valve has been out since 2013. And there are actually 1 to 3 cases according to Ziad Hijazi, that they actually did valve in valve in these patients. Harmony is the same thing, and I've showed you some of the examples that have been performed. Altera, Edward, and of course you have an Edward at 29, and we know that the bioprosthesis valves that are surgically placed from Edward company, we've been placing valve in valve in them. One of the things that important is the radial force, and this is actually a very, very important, and one of the earlier, issues with, complication or issues with them is the radial force of the device and the delivery stiffness. You have to differentiate. The delivery system stiffness is basically how stiff is that whole shaft going through the heart, across the tricuspid valve, into the RVOT and being positioned, how difficult it is taking that loop. The venous P valve and the Altera is taking the lead in this area, not as stiff as bad, but definitely the Harmony, utilizing the laser cut, becoming less stiff. From RVOT point, from, radial force, we know both the venous and Harmony are very soft system. So it is, this is why the coronary compression in this part of these two valves has been very, very remote or less. Only 1 or 2 cases, and the coronary angiogram with the chest occlusion is being less and less used, unless if you are early experienced, and we've been counting on the CT scan to give us, red flag if the coronary is close by, needed a chest occlusion with a coronary angiogram at the same time of implantation before you put the valve in. So the radial force is important to consider in these two valves. Altera system is more of a stiff, so maybe when you have partially calcified RVOT, recoiling, the Altera may be of a choice to you, remembering that because of it's stiff. So this table will give you sort of like direct you which area you go to, which part of the valve you utilize, depending on your patient and population referral. This is sort of like the idea. This is my personal sort of like cheat sheet that I keep in my mind when I pick which valve I pick for each patient that I implant valves in. And I think I'm going to be stopping here and leaving you guys with questions. If anybody has any question, please